Welcome, everyone. Thank you so much for all of you who are able to join today for what is the second session of our 9-part series, Best Practices for Working with Refugee and Immigrant Youth. And we will be hearing today about cultural responsivity, and we have a fantastic panel lined up for that. These sessions, as you may know if you've been in attendance at the first session, this is a 9-part series that is being put on by the staff and faculty of the Trauma and Community Resilience Center at Boston Children's Hospital and Harvard Medical School, with support from SAMHSA as part of the National Child Traumatic Stress Network. So with that, I'm going to turn it over to Caroline, who can do a little housekeeping, and then we will jump into the heart of the matter with our fabulous presenters. Thank you so much for joining today.
Thank you, Heidi. Yes, and as Heidi mentioned, hello and welcome everybody to the best practices for working with refugee and immigrant youth. This is our second session in our 9-session series. Today is cultural responsivity. And then the next sessions will take place approximately once per month in the coming months. Already by registering today, you will be receiving information about our upcoming sessions. You're in our listserv, so you'll be hearing more from us, including our next session, which will be on Monday, March 21st at noon Eastern time, on the topic of forced migration experiences. If you missed our first session, intersection of trauma and culture, we will populate in the chat the link to our YouTube channel where that recording is housed, as well as the recording from today's session will be in the coming days. These sessions are intended for a mental health audience, but it is open to everyone. The series is created to be introductory level as well as experiential and interactive. However, we're expecting a very large group today, over 500 from across the United States, which we are very excited about. However, due to the large group, we do ask that you keep yourselves muted throughout the series, throughout today's session. And if you do have questions, please utilize the chat. We love your questions and comments. And we will be ending today's session after our presentation with a Q&A. So we will get to discussing those at that time. In addition, after today's session in the coming days, you will receive a follow-up email from me, including the link to this recording, a PDF of our slides, and a post-survey link so that you can get CEU information certificate for those who are social workers and psychologists. So yes, you will get a copy of the slides, you will get a link to the recording, and CEU information will be included in a follow-up email later this week. Before we begin today's presentation, we'd like to start with a land acknowledgement, which reminds us all that colonization is an enduring reality and recognizes the traditional lands on which we live, work, and study. We here at Boston Children's Hospital in Boston, Massachusetts, recognize that this land was home to the Mashpee, Wampanoag, Akina, Wampanoag, Mimpuk, and Massachusetts tribal nations, and my apologies for the pronunciations. We also acknowledge the legacy of slavery in our region and the enslaved African people whose labor was exploited for generations to help establish the economy of our region and the United States. We ask you to join us in acknowledging these communities, their elders, both past and present, as well as future generations, and acknowledge that Massachusetts was founded upon exclusions and erasures of many Indigenous and African people. Now I will let our wonderful panel of presenters, Luna, Farah, and Jeff, introduce themselves and kick off today's presentation.
Great, thank you, Caroline. Hi, everyone. My name is Luna Acharya Mulder, she, her pronoun, and I am a psychologist at Boston Children's Hospital, where I do trainings and provide consultation on providing culturally responsive, trauma-informed mental health care to refugees and immigrants resettled here in the US. And then in terms of my cultural background, I am originally from Bhutan. I'm Bhutanese, and most of my family resettled here in the US as refugees in the last 10 years from refugee camps in Nepal. Now I'll pass it over to my co-presenter, Farah.
Hi everyone, my name is Farah Harawi, she, her pronouns. I am currently a PhD student in the Counseling Psychology Department at the University of Massachusetts in Boston, and I'm currently working with Luna and Jeff and the rest of the team at the Trauma and Community Resilience Center on this best practices series. I am a second generation Afghan American. My dad resettled to the United States as a refugee during the Soviet invasion of Afghanistan, and I grew up here in the United States. Unfortunately, I'll only be here until 12:30 today, and then I have to hop off. But if there are any questions for me at the end, please feel free to send me an email, and I will pass it to Jeff.
Great, thanks, Farah, and thanks everyone for being here. My name is Jeff Wenner. I'm a clinical psychologist and researcher at the Trauma and Community Resilience Center, and really thrilled and honored to be here today to present this information. I use he, him pronouns. I grew up in Connecticut, North Carolina, and Massachusetts. My dad's family is of Ashkenazi Jewish background. My grandparents on that side grew up in Malden and Chelsea. On my mom's side, my grandparents grew up in Queens, New York, and in New Jersey, and mixed European ancestry with Italian Catholic as sort of the centering identity on that side of my family. And I really come to this work, trying to contribute at the intersection of social justice and youth and mental health service provision. So we're thrilled to be here sharing this information with you all today, and I'm so honored to be presenting with my colleagues Luna and Farah. The learning objectives for today are really to give participants an opportunity to enhance understanding of three frameworks, which are cultural competency, cultural humility, and their combination, which is culturally responsive practice. And we'll be talking about culturally responsive practice through strategies with engagement, assessment, and intervention in mental health service delivery. And while these are frameworks that have been studied for many years, what we're trying to do here is really provide folks with strategies that you can walk away with from today and start using this week. So we'll be anchoring these ideas around a fictionalized case example. And so we'll be drawing on a case example of an adolescent boy named Abdul. So Abdul is a 14-year-old boy. He's a refugee from Afghanistan living in Boston, Massachusetts with his mother, father, and 4 siblings. And they've arrived in Boston about 6 months ago. They're eligible for a special immigrant visa, an SIV, but the paperwork has not yet been fully processed. Abdul and his family's primary language is Pashto. Abdul loves soccer and listening to music, and he's been referred for mental health services from his school because of concerns about aggressive behavior and oppositional behavior. And so from that referral, this could be sort of treatment as usual. What could happen in a sort of mental health service revision as usual? So Abdul and his mother are referred to a hospital psychiatric clinic. So I'd like to provide a clinical vignette to try to showcase some of the processes that we'll be trying to explore and dig into today. So this is, imagine this is a setting in a hospital psychiatric clinic. So Abdul and his mother Sadaf are in the waiting room at a hospital's psychiatric clinic with a hospital interpreter. An English-speaking clinician greets them and explains the process of therapy, consent to treatment, and confidentiality. And the interpreter and the mom speak in Pashto. As they engage, the interpreter then turns to the clinician and in a slightly sheepish voice says, she says her son isn't crazy and doesn't need to see you. She'd like you to sign this form so he can go back to school. And the school says he can't return until you fully verify that he's safe to be in school. And now this, these few sentences, this vignette is incredibly common. And if you work in refugee youth mental health, you've likely heard a story like this. And what's important here is this is not a story about a mother who doesn't love her son, about a mother who has not committed much of her life to his and his siblings' well-being. It's a mother who is trying to protect her son, trying to navigate a complicated situation, and using the learned histories that she has to do that. And what can occur with that is then we see that for some refugee and immigrant families, not all, mental health services may be seen as useless at best and harmful to their family and community at worst. And so then one of the challenges, one of the really opportunities in mental health service for youth and families of refugee and immigrant backgrounds is, how do we open the door for services? And so how do you as a provider, how do you as a program leader, how do you as a policymaker, how do you effectively and compassionately open the door to services for Abdul and his family if mental health care services are indicated? What competency and humility strategies could you respond with, for example, in this clinical encounter or across clinical encounters, to increase the likelihood of intervention success? Because in that previous vignette, the likelihood of really genuine and sustainable psychological healing, if Abdul and his family are in need of that, is low. And so two frameworks that have been sort of put forth over the past more than 2 decades to try to provide cross-culturally engaged multicultural counseling are cultural competency and cultural humility. Competency, and folks may be familiar with one or both of these terms. Cultural competency is a set of behaviors, attitudes, and policies that come together to support cross-cultural encounters. And it's an approach that is really focused on what to say and do, what to say and what to do, and what not to say and not to do when working with others, cross-cultural others. And these are all sort of in quotes. And it's often very concrete and very goals-oriented. And a strength of cultural competency is that it's easier to assess providers or programs' effectiveness or knowledge of a particular topic. And it can help start to bridge cultural distances that may prevent service engagement. However, there are many pieces that are not built within the cultural competency model and often fall short if that's the only strategy one uses. On the right side of the screen, cultural humility was actually a response to cultural competency around how do we get into this work in a way that may be more genuine, more authentic, and more sustainable. Cultural humility is a commitment to lifelong learning and self-reflection. So the focus is actually often more on learning about ourselves than learning about others. Recognizing and changing power imbalances in relationship, understanding that, for example, in a provider-client dynamic, there is often inherent power context that is there, and then how do we acknowledge that and then navigate that? And then third is advocating for institutional accountability, which is the piece that often programs and institutions are the most wary about. However, it may be, it's just as important, because sustainable services built into systems that outlast an individual's work at that program are what's going to make really lasting change. And so it's our belief that the combination, the interaction of competency strategies, what to do, what not to do, how do I learn concrete information, and then also humility strategies, how do I engage in a deep personal self-reflection, a lifelong learning about who I am, how that informs how I move through the world, and then how do I navigate power and hold the institutions that I have the opportunity to work for accountable. That's really where culturally responsive practice is, and that's the kind of work that we work on in our program. And so if I was a provider in this context trying to work with Abdul and his family, if I'm trying to first build my competency strategies, some of the work that I would be doing would be the work that my colleague Farah is going to share with us now.
Thank you, Jeff. Yeah, so since today we're looking at the case of Abdul, who's from Afghanistan, in order to best work with him, it's really important that we learn a little bit about his background. So I'm just going to very briefly go over the modern history of Afghanistan. This is very brief and not an extensive account by any means, but beginning back in the late 1970s, Afghanistan was invaded by the former Soviet Union following a communist coup and a takeover of the government. At that time, then we see a Mujahideen opposition form and begin fighting against the Soviet invaders in order to take back the country. We also see during this time millions of Afghans leaving and seeking refuge in other countries. My father, for example, being one of those Afghans. And then in 1989, Soviet forces were defeated and withdrew their forces, and the US, Pakistan, Afghanistan, and the Soviet Union at that time signed peace accords in Geneva. And so then following this period, the newly formed Islamic militia, the Taliban, rise to power in the mid-1990s. And so during this time, Afghanistan faces a famine, drought, there's ongoing fighting within the country, in addition to these drastic changes in daily life due to the Taliban's strict interpretations of Islam. And so we once again see millions of Afghans fleeing into neighboring countries. Then the September 11th attacks in New York lead to US and British forces launching airstrikes and invading Afghanistan. And this begins the war in Afghanistan, which now we are 20 years later from that moment in time. And in the past summer of 2021, the US withdrew their troops, and the Afghan government then collapsed within days back into the hands of the Taliban. And so now we're once again kind of witnessing this next wave of Afghan refugees once again escaping Taliban violence in the country. And so that's just the last few decades of history in Afghanistan. And so it's important that we also kind of take a look at family life, roles, and the culture of Afghanistan. Again, this is just very general information, and it would be important to get a more specific understanding from the individuals and families we work with. So for the case of Abdul, we would still want to find out information about his individual family experience. But just generally speaking, Afghanistan is a very diverse country. It's home to various ethnic and linguistic groups. There are many languages and dialects spoken across Afghanistan, with the official languages being Pashto and Dari. You might also hear Dari being referred to as Farsi or as Persian. Just a very basic explanation is that Dari and Farsi are two accents of the same language, and Persian is a term used in English-speaking countries like the US to refer to the language. So not only are there these various linguistic groups, but there's also various ethnic groups. There's Tajiks, Hazaras, Pashtuns, so on and so forth. And so there are similarities and differences shared across these groups. And so it's important to know that there may be some practices that are unique to certain groups and others that are similar across the board. So one similarity across the board in Afghanistan is that people tend to live in multi-generational homes. So you have grandparents, children, grandchildren, sometimes aunts and uncles, all kind of living under one roof. And both outside and within the home, there may be a physical separation of men and women. So if you look at the slide, the picture on the top, this is actually my own family in Afghanistan back in March of 2021. And so hopefully you can see that though we're all sitting together as a family and having a picnic, just naturally the men in my family sat together in the back and the women in my family sat together towards the front of the photo. And this is quite typical to see in Afghanistan. Outside and social settings as well, you might see this separation by gender. Though there is a tendency to have kind of more strict gender roles across the country, in the past 2 decades, there have been more girls and women going to school, working. And so over time, especially in more urban cities, such as the capital of Kabul or Herat, these lines have become a little bit more blurred, and you see women partaking in social life and taking on different roles within the home. However, in more rural parts of the country, there still may be adherence to these more defined gender roles. It's also really important to be conscious of gendered interactions, especially across genders. So typically interactions between men and women might not involve shaking hands or other forms of physical touch, though shaking hands is often seen between men. Afghan women tend to greet other Afghan women by kissing each other on the cheeks. An appropriate greeting between all people, not just between men and women, is a hand on your chest. You can see in the photo on the bottom of the Prime Minister of Canada putting his hand on his chest to greet a woman. And so these are just some cultural aspects to be mindful of. All right, and so due to decades of war and violence and conflict within Afghanistan, we of course see that there are negative impacts that these events have had on mental health, with high rates of PTSD, depression, and various other mental health concerns. Many might only seek mental health care as a last resort. There's a tendency to kind of keep problems within a family and not go out with that information. In terms of healthcare and treatment of mental health symptoms, because psychiatry is an established medical profession in Afghanistan, people may be more familiar with going to see a psychiatrist and being prescribed medications versus counseling and therapy, which are not as well established of a profession in the country, and there only are maybe a few handful of trained counselors, psychologists, social workers within the entire country. And so there's less familiarity with the kind of the talk therapy services that we see being utilized in Western countries. But because Afghans are of a collectivist culture, there may be some benefits to group therapy over individual therapy, especially in groups with individuals of shared experiences. And so now that we kind of have some information that could inform our cultural competency, I'm going to pass it back to Jeff to speak on the culture of humility.
Wonderful. Thanks so much, Farah. And so again, that's some of the information if you were a provider new to working with an Afghan individual or community that you could draw on to provide context. Now, in addition to the competency strategies, what to do, how to engage, what's the context, we want to engage in the work of culture humility, which is really around remaining curious and reflecting on our own social and cultural identities. And this is really a lifelong endeavor that I really invite folks to consider as a strategy that you'll continue to use across your life and across your professional experiences. So key strategies here is to not make assumptions and to remain curious and open. We want information to be a context that helps inform our service delivery. We don't want that to solely inform the content of what we talk about and how we engage with a family. We want to acknowledge that we're all biased, even if we wish we weren't. Just by being born in the world, we are downloaded with so much complexity. And part of the work of culture humility is upgrading that software so that way we can communicate and engage with folks in a way that's value affirming and effective. In the context of those biases, although we all hold biases, we may not all belong to dominant or privileged cultural groups. Again, I'm a white man, and so according to my gender identity and race, those are both groups that have been historically and currently privileged in my cultural context. When bias is reinforced by powerful groups and social structures, for example, institutions in power, the results are systems that perpetuate oppression, and these can be overt and they can be more subtle. And so the challenge here is, how do we take this very complicated, very sort of fluid way of understanding our identities in the context of others and really put it into practice? How do we intentionally explore our intersecting identities and take action to better serve families? So again, the key here is, how do we engage in a self-reflection that then informs our actions and the committed actions towards helping other people? And one of the strategies that our group has used, or one of the tools that our group has found helpful, is a framework called the Addressing Framework, which is a framework that was developed by our colleague Pam Hayes, who's a psychologist based in Alaska. And it's a tool for thinking about intersectionality. It's a tool for understanding that we all have a diversity of social and cultural identities. There may be identities that you think about all the time, every day, and some that you may have either not had the opportunity or had a privileged blindfold that sort of prevented deeper engagement. And so Pam's framework, the Addressing Framework, it's an acronym, is one tool that you can use both for your own self-reflection, and then it's something you can also use to engage with clients in this work. And there's a lot of online tools related to this tool. And so again, some of the identities that you may be thinking about are broaching: age and generational influences, physical health and physical health history, mental health and mental health history, religion and spirituality practices, race and ethnicity, socioeconomic circumstance, occupation and military involvement, sexual orientation and expression, indigenous heritage, national origin and immigrant status, and then gender and gender expression. And this does not contain all the social and cultural identities of the human experience. However, it's the tool that, at least in my own personal journey in this work, is a succinct way of trying to, again, open the door for our own exploration. So that way we can try to engage with this work. And you can see that as we start thinking about intersecting identities, how all of these pieces play out. And again, we're not just one of our identities, we're all of those identities together. You can see how it can play out in really concrete situations. So imagine the clinical encounter with Abdul. Imagine how it could be similar or different if the clinician, say a licensed clinical social worker, who greeted Abdul in the waiting room was, for example, a 60-year-old white woman whose parents immigrated from Italy, a 27-year-old Black man whose parents grew up in Boston, and a 42-year-old Syrian woman who moved to the US 5 years ago. These are all, again, in this example, they're all licensed social workers. They all work at the same program. They have offices in the same place. All of those pieces on paper may be the same. However, the reality is that in that moment, in that clinical encounter, there are many pieces at play related to their lived histories and current identities, and then how that interacts with Abdul and his family. And then the opportunity is, how do we understand those pieces and move together in a way that really helps engage Abdul and his family in the services to again, help him move towards healing. And so this is, again, the strategy of trying to engage in cultural responsivity, thinking about competency and thinking about humility and how those pieces come together. And now you may be thinking, okay, well, these sound like interesting ideas, or it sounds like good in theory. Does it actually work in practice? So we know from a huge amount of literature, a huge amount of research, that overall culturally responsive interventions or culturally adapted interventions, ones that really place culture at the center, are likely to be more effective than traditional unadapted interventions, especially for youth and families of minoritized identity backgrounds. And this is really an example of equity in action. Equality is treating everything the same. Equity is providing people what they need to be able to sort of maximize their opportunity for effectiveness, healing, success. And that's really what these interventions are trying to do. And examples of adaptations often involve changes in terms of existing service, if you're trying to adjust it so it's more culturally responsive. What could that look like? Well, it could involve changes in language of delivery, the format of delivery, the framing of services. For example, why is the service valuable and what will we, the providers, do? And then the context of service delivery. And these are all big ideas themselves. You could have a whole presentation about each of those, and we'll provide some examples in the model that we work on in our program, Trauma Systems Therapy for Refugees, about how we do some of this work. Now I'm going to turn it over to my colleague, Luna, who will be talking further.
All right, so how do we engage Abdul and his family in a way that is culturally responsive? So first and foremost, we want to make sure that, because English is not their primary language, that we work closely with a qualified interpreter or a cultural broker. So ideally someone who speaks Pashto and is from Afghanistan, to do that outreach with the family. We want to be thoughtful about the framing of services, given the stigma that's associated with mental health services, or just the general lack of familiarity with the service for many cultural groups. So framing it in terms of helping Abdul with his success in school, or helping the family with adjustment in a new culture can help open that door to services for families. Then after practicing cultural competency and learning what we can about Afghan culture and norms, and also practicing cultural humility, so not making any assumptions, we then ask informed questions about the family's culture, religion, food, holidays that they celebrate, with curiosity. It really helps if you know something about the cultural background, the history, the politics, to really help close that gap. And then we ask informed questions with curiosity. Generally speaking, people are really proud of where they're from. And so, asking thoughtful, informed questions can really help build that rapport and that relationship. And then also in practicing cultural humility, we want to reflect on our own identity and different aspects of our identity. So age, gender, culture, our access to privilege, our bias, and how all of those things could impact the clinical encounter. So awareness is really key in that cultural humility piece. We want to provide concrete help to Abdul's family. So we know that they came here on a special immigrant visa, but it's not yet processed. So what that means is that they are eligible for benefits like cash assistance, food assistance, employment support, similar to what refugees receive, but that they may have to apply themselves. And so asking about basic needs and supporting them through case management services will be important, both to relieve stress for the family and also to really help build that trust and to see mental health services as something that could potentially be beneficial for them down the road as well. And then once we begin services with Abdul, really being thoughtful about how we engage him in the sessions. So thinking about what we know he likes and trying to see if we can integrate them in our meetings with him as well. We want to avoid using clinical jargon if possible, because it may not translate very well into different languages. So how might you explain a psychological difficulty without using mental health terminology? We have found that using a physical injury as an analogy to psychological injury can be helpful. So for example, something like, imagine you broke your leg because of an accident, your leg is injured and you are feeling a lot of pain. In order for our leg to heal, it will need medicine, care, support, exercise, and time. When a person has been through a lot of hardship and suffering, their mind can also become injured. The mind can also feel a lot of pain. The difference between the leg injury and the injury of the mind, however, is that pain in our mind is not visible to most people. The mind, or a pain on the inside, can also heal in a similar way as the leg, through medicine, care, support, exercise, and time. And so the care, support, and exercise piece would be the therapy or the counseling that we're talking about. All right, so now we are in the assessment phase of treatment, right? So how do we gather information from Abdul's parents and other important people in a way that is culturally responsive, right? So of course, because again, Pashto is their primary language, we want to make sure that we are working closely with an interpreter or cultural broker. And then we're asking questions about their migration history, right? So where were they before they arrived in Boston? All the different various places that they may have had to live either temporarily or for longer term. We want to be asking about their trauma history, and I'll talk in a minute about how to do that in a way, again, that's sensitive and culturally responsive. We want to be asking questions about Abdul's developmental history. So, what he was like as a baby, as a toddler, as a younger child, his educational history, his health history, just to learn as much as we possibly can about him and his family. We want to be asking about core stressors in resettlement, so other stressors that the family is dealing with currently. We want to also ask about goals that each member of the family has. So what is it that they want to work on? It can really help inform motivation as well once we begin treatment. We want to be asking about concerns and also paying attention to family dynamics. So power, who gets along with who, what are some of the dynamics in the family, paying attention to that as well. We want to understand the family's understanding of mental health system here in the US, and then their understanding of the cause of what's happening. So how do they make meaning and make sense of what's happening? And then who do they typically go to for this kind of help? So help-seeking behaviors. In any trauma-informed care, we want to be asking about strengths and building on strengths. So what is Abdul good at? What's going well in the family? And then building on that down the road. And then we want to also be asking about barriers, so potential things that could get in the way of accessing the service. Gathering the trauma history with Abdul's parents, this may take time and trust to gather. Some may say no trauma, which is actually really common, which is okay. We don't want to push. Whereas others might actually think that this is now their time to share their full stories. And if that happens, where they start to really go into really intimate details about some of the worst moments of their lives, we really want to slow them down if they begin to go into those details and emphasize that we want to hear what they have been through, but we want to do it in a way that is at the right time. So having clients tell and retell the worst moments of their lives could potentially be dysregulating and not clinically sound practice during this very, very beginning stages. So the assessment phase, when we're just meeting them for the first or second time. So we just want to be thoughtful about asking about the trauma history, and we want to do it where it's contained and it's sensitive. So asking in more of a list format it is ideal. And then lastly, there may not be a word for trauma in other languages. So a narrative with examples of what we mean, an interpreter or cultural broker would need to think through how we would explain it. So something like, Many people experienced sad and scary things during the war and during displacement. So for example, death of loved ones, physical harm, seeing others get hurt. Did you experience anything like that? And then as we are gathering information from the parents for billing purposes, we do have to start thinking about diagnosis. So the DSM, just a little bit of history, the first version of the DSM was developed in 1952. It was very short and it did not incorporate cultural factors when considering diagnoses. We've come a long way since then. The most current version is the DSM-5, which was developed in 2013. And it does have a definition of culture, which is right there. And it does a better job of incorporating cultural factors in diagnosing. The mental illnesses found in the DSM can be found throughout the world, but the particular symptoms, the course, and the social response are often influenced by local cultural factors. So for example, it's really common for people to have somatic symptoms like physical aches and pains as a symptom for psychological pain. So that's one example. The DSM-5 also has the cultural formulation interview guide, which is towards the end, and Amy's going to put a PDF of that in the chat as well. But this is a really helpful tool that really just directly asks questions around cultural factors in meaning making and in help-seeking behavior. So there's 16 questions that clinicians can use to obtain information about the impact of culture on key aspects of the individual's presentation. It will allow Abdul and his family to define their distress in their own words. There are 4 domains. So we have the cultural definition of the problem. Domain 2 is cultural perceptions of cause, context, and support. So each domain has a few questions underneath each one. So asking about how do you make meaning of this, the cause is really important because in some cultures, there's more of a spiritual or a religion explanation for health problems. So we want to really make sure that we're not missing anything big and asking the right questions. Domain 3, cultural factors affecting self-coping and past help-seeking. And then domain 4 is cultural factors affecting current help-seeking. Here are some help-seeking examples for Afghans, some Afghans, seeking support and help from a religious healer like an imam is very common. Praying, Farah had mentioned that psychotropic medications is more known and people might prefer that over therapy. So understanding that will be really important, and then support from family and friends as well. And then here are some examples of help seeking from Bhutanese refugees. So seeking support from traditional healers is also really common across many different cultural groups. So for Bhutanese, seeking support from an astrologer or a witch doctor, what we call a dami, a priest, taking herbal medicines. I'm not going to go into what each one of these is, but just to highlight that this is, these are community-based approaches. And so asking about these and seeing if there's a way to combine and integrate both Western mental health practitioners' recommendations for intervention as well as community-based approaches tend to be the most effective. So if there's a way to possibly integrate that as we develop our treatment plan, that can be really helpful.
And so now Luna provided some beautiful examples, both from Afghan culture, from our own Bhutanese culture, around how do we, again, open the door. And what we'll now be shifting to is providing some concrete examples based on strategies that could be used within trauma systems therapy for refugees, which is an evidence-informed psychotherapy and organizational model that myself and Lynn and our colleagues at the Trauma and Community Resilience Center work on to try to provide culture responsive services. And so it's and this is a very quick overview, it's a tiered based public health informed model. And so what I'll be doing now is trying to provide some brief examples of if we were to revisit Abdul's case, where a culturally responsive and sort of organizationally embedded model has been included in a school or a hospital, what could that service provision look like concretely? How could the both referral, engagement, and interventions be different in a way that, again, is more effective in terms of treatment, it's more enjoyable, acceptable for the family, and it's more sustainable for the community. And so this would be Abdul revisited. So remember the context, the background. Abdul's a 14-year-old boy. His family has been in Boston for about 6 months. And there is a referral from a school-based provider for mental health services. If we were to really wrap this around a school or a local community, maybe this is what the referral could look like. And I'm going to walk through each piece. So Abdul's mom, Sadaf, arrives at school to pick up Abdul, who is attending a Tier 2 skills-based group. An Afghan cultural broker, Dina, who co-leads the group with Julie, a school-based clinician, exchanges greetings and pleasantries with Abdul's mom, catching up briefly about community news. So in that encounter alone, there's actually a lot happening there that's incredibly important for building service programs for refugee and immigrant youth. And here there is Tier 1 and Tier 2 of trauma systems therapy for refugees. So what's happening here is Tier 1 work is this deep community partnerships with cultural brokering, which occurs across all levels of the intervention. Those are folks, from the community who speak the language, understand the culture, are embedded within a community, who can then co-deliver services with mental health providers who may already be in the system. And so community engagement, mom interacts with the cultural broker in a way that feels organic and kind and focused on strengths and connection. They already have a relationship. And then the engagement with a skills-based group that the cultural broker and a non-Afghan licensed mental health provider are running together, embedded in the school. The provision occurs in the school and is focused on strengths and school effectiveness, as opposed to being in a hospital focused on illness. So that's just one way of trying to open that door, decrease stigma, and increase engagement. So now again, imagine this encounter. Dina then describes Abdul, this is to the mom. Dina then describes Abdul's positive progress in the group. She explains, however, that he's continuing to have trouble in the classroom and became upset earlier, knocking over some desks. Maybe this is some of the aggression or oppositional behavior that we heard about earlier. Dina then asks if she and Julie could meet with Abdul to discuss how Abdul could succeed at school. How could he be more effective? So it's an opportunity for engaging within the TSDR framework, and Luna will talk about this more, about school-based or outpatient level psychosocial services. And so as we would call this, regulation-focused intervention. And Luna will talk more about that in a little bit. And then another component, Dina also added in this conversation with Sadaf, Abdul's mother, that she knew that Sadaf was managing a lot at home, understandably, given the context, and that she, Dina, the cultural broker, and Julie could try to support those needs, including strategies for helping Abdul making safer choices at home and more effective communication with his mom and dad. Sounded okay to Sadaf, and she nodded in agreement, and a meeting was set up for later that week. And so this is a way of trying to build a bridge for home-based services, really caring for caregivers, and really building tools at home that then can support Abdul and again, his work in effectively navigating this new cultural context, this new school that he and his family are navigating. And now I'll turn it over to Luna again to share a little bit more about that Tier 3 work.
All right, so what does culturally responsive therapy look like with Abdul, right? So the Tier 3 school-based therapy. So first and foremost, we want to make sure that the cultural broker and the clinician, so Dina and Julie, meet beforehand, before each session, to review the goals and the purpose and exactly what will be said in Pashto to Abdul, right? So giving the cultural broker time to think through, all right, how does this translate? How would I frame this? And talking through all of that before each meeting, ideally, to make sure that things translate well, and the framing is, we can be as thoughtful as possible about that. And then each session should emphasize safety, consistency, empathy, attunement, and really building that trust and relationship with Abdul. So clinicians, can lean on their clinical skills and interventions that they typically use, right? So we don't, just because now culture is involved doesn't mean that all the things that we've learned about how to engage kids and families in clinical interventions goes out the window. We can still lean on that and use those. But the biggest difference is that you're not doing it alone, and that you're working closely with somebody who is from the culture to make sure that everything that we're doing and saying is appropriate, and that we're not missing anything big. We also want to create space where Abdul can explore and express himself through art and play and music and sports and other mediums that he enjoys. So whatever therapy space you're using, making sure that there are things in there to really engage him and help him express what's going on, so that hopefully he wants to keep coming back each week. And then using time, using each of the meetings to really listen and learn about his daily experiences, processing incidents of dysregulation. So we know that he had an incident of, where he did something in the classroom, and it was the people were concerned about it. So asking about that again, not with like, you're in trouble or anything like that, but with empathy and really through this trauma-informed lens, meaning wondering, what happened to this child, and not what's wrong with you, and providing that information and education as well to all the other important adults in Abdul's life, and sharing his triggers. So whatever we learn about him in our meetings in terms of what might be setting him off, and then also coping skills, things that work for him to help him when he becomes dysregulated. So sharing that information with other important adults. And then ultimately the goal of individual sessions with Abdul is to teach emotion regulation skills. So emotion identification skills, and then expressing those emotions and his needs in ways that are healthy, and then developing healthy coping skills as well. And then after each session, again, the cultural broker and clinicians, so Dina and Julie, should ideally meet after each session as well to debrief and talk through anything that happened in the meeting, anything that came up that maybe somebody might have missed out on, or maybe Julie didn't quite get because interpreting was happening and not everything was interpreted. So just making sure that nothing was missed, nonverbals and verbals. So being thoughtful about pacing of what's being said as well, so that everything that is said is being interpreted as well. So, but meeting after that just to debrief as well can kind of close that gap and miss information that might happen. And then what does therapy look like with Abdul's family? So the tier 4 in-home services. Again, Dina and Julie are meeting beforehand to talk through exactly what will be said to the family prior to each session. And then ultimately what's happening in this, in this phase of treatment is the focus is on safety, and we're providing psychoeducation on trauma to the caregivers, including Abdul's triggers and coping skills. So what we learned about him in terms of what might be setting him off and why, how is this connected to what he's been through, and then some things that might work for him. And then how can everybody else in the family, what can they do to help support him so that they're responding in a way that's helpful and not harmful. Also with the family, we want to be teaching communication skills and parenting skills in a new context. So communication skills are things like active listening skills between family members, building empathy between family members. So really helping the family members listen to each other and talk about what's going on in a way that everybody's going through their own acculturation process. Everybody's in a different state in terms of acculturation, where kids are acculturating faster than adults. So having people really talk to each other and share each other's experiences is kind of helping build that communication skill. And then parenting skills, so working with Abdul's parents around parenting in a new context, BRYCS, which Amy will put another resource in the chat on, raising kids in a new context, and just different information and things that would be helpful for caregivers to know. Obviously, they know how to parent. They've been parents for many years, but some of the things that they might have used back in their country of origin might not necessarily work here, and just information about laws and safety and things like that is really helpful for caregivers to know. So this resource has a lot of information in there around raising children, raising teens in a new context. And then we want to incorporate families' method for help seeking if possible. And then parents may need to be referred for their own individual treatment or group therapy. We found that oftentimes caregivers, because of their own trauma histories, it can sometimes get in the way of how they parent. They've got their own triggers and their own mental health issues that they need to work through. And this is very common, so we want to be thoughtful about that and refer for their own either individual or group therapy, maybe talking to other caregivers that are going through similar experiences as well. Consider and refer for medication if needed. If after many months and hard work from everybody, things still aren't really shifting or changing much for Abdul, it is okay to consult for medication as well. And then ultimately, the longer term work with the family is really around helping the family develop a trauma narrative and telling their story that's focused on strength and resilience. And then after each session, Dina and Julie, the culture broken clinician, again, they're meeting after each session to debrief. There are a lot of challenges with balancing the clinical with the cultural, including things like navigating boundaries. A lot of times culture workers are living in the same community as the family, and so important to talk through all of this after each meeting, but also in supervision as well, to really help navigate some of these challenges.
Great, thanks, Luna. And thank you all so much for being here today. We've covered a lot of information, and we hope this is information that you can put into practice now, and then information that can also guide you for many years ahead. Really, the work of cultural responsivity in mental health practice is a journey. It's a lifelong journey that really we're all on. So again, this is an opportunity for us to co-voyage together. And it's really an appeal to both the head and the heart. The head, insofar as the data is there, these are interventions that are likely to be more effective. These are strategies that have been proven across cultural groups to be more effective if we can then apply those and adapt those. We know that it can lead to cost savings in behavioral health programs, lower no-shows, more effective referrals. And it's appeal to the heart because there are a few things more painful than having aspects of your identity invalidated. Who you are or how you are in the world is not accepted or not valued. There are a few things more painful as a human being. And we know that by building more culture responsive interventions, we're able to engage folks with the kindness and compassion we want to receive ourselves or for our loved ones. If you have questions for Luna or for myself or for Farah, feel free to email us. We're happy to engage and talk further. And we mentioned a number of resources today. Again, we'll be sending these out, and they've also been placed in the chat. These are just some of many of the wonderful resources that are evidence-informed, trauma-informed, culture responsive online that can help guide your practice with refugee and immigrant youth. We really appreciate the opportunity to share this information with you. Thank you so much for your attention, and I'm going to turn it over to Caroline.
Thank you, Jeff, Luna, and Farah. Wow, that was really meaty, really important information in a short amount of time. So thank you. I know from my own practice that cultural humility can be a lot like self-care, right? We talk a lot about it in the field. It's really easy to say, but really difficult to do, and yet imperative and really a prerequisite to any of the work we bring going to any room with any client. And I think that being said, I'll start kicking off our Q&A session. And with a few of my questions, but please, audience members, populate your own questions, comments. We love it all in the chat. We'll hope to get to it. But with so much that you presented and spoke about today, what would you say you want kind of the one big piece, the one big takeaway for our audience to leave our presentation today with? You know, we're about to hit the top of the hour. Let's say we have a refugee or immigrant youth walking into our office at that hour. What would be kind of the one thing to bring?
Yeah, from my perspective, I would say cultural responsivity is a combination of cultural competency and cultural humility strategies. And there are likely ways that you can put both of those into practice into 5 minutes before your clinical encounter. Again, you can't do all of that work, and there's likely something that you can do that can move it forward at least 1% on both of those metrics to increase the likelihood of a culturally responsive intervention.
Great. I know a few questions came in over the chat during the presentation about cultural brokering. I'll just mention that we are planning a full session later in our series about working with cultural brokers and interpreters. Currently scheduled for June, but stay tuned. Luna or Jeff, do you have any kind of anything else you want to share about cultural brokering, either how to find cultural brokers or where someone might be able to find more information about them or training about cultural brokering?
Yeah, so cultural brokering isn't a role that currently exists within our healthcare system, at least when we do billing. And so a lot of the cultural brokers that we have that we're working with around the country are paid for and supported through grant funding. But what other programs have also done in terms of sustainability of this program is to think about how to use interpreters or case managers, which is part of our mental health system, to train them in the role of the cultural brokering, which is different from interpreters. Interpreters are trained to interpret word for word and not go outside of kind of what's being said in the meeting, whereas cultural brokering, they really do a lot more than that in terms of adding context and background information. And they're considered as part of the treatment team. And so a much more in-depth training is required. And so we will be doing that at some point in our training series in the future.
Great.
And can I add one other piece, Caroline?
Please.
One tool, you can think about the term cultural brokering as both a noun and a verb, meaning cultural broker is the role, is the person. However, often, as Luna is saying, there may or may not be a job designation in the HR infrastructure that says cultural broker, and often it's the verb, the action of cultural brokering. That's the key ingredient we're talking about. So it could be, again, an interpreter or a community navigator or a social worker, who that's the HR designation. However, they are doing the work of cultural brokering to try to, again, open the door for service.
While we're on the topic of cultural brokering, there was another question around what supervision might look like with having a cultural broker be a part of the team. Again, I think we'll get into that a little more in our upcoming training, but wanted to mention it here.
Yeah, so ideally supervision is provided in a dyad form. That's kind of, with the clinician and the cultural broker meeting together with a clinical supervisor. And talking through cases together so that both the clinical and the cultural aspects of each case are being considered and thought through during assessment, engagement assessment, and treatment planning, and then treatment intervention. So ideally together in a dyad. And then, what a lot of programs have also done is having cultural brokers who are more experienced and have been doing it for a while supervise the newer cultural brokers as well. So that's also a really nice setup. that mentorship supervisory relationship for more experienced culture brokers has also worked really, really well. So ideally in a dyad, but maybe more individual supports for cultural brokers with more experienced culture, people who've been doing it for a while.
Thank you. And I see a hand up. Is it Melissa? Would you like to ask a question to our panelists? If not, I would, continue to encourage and direct everyone to typing questions and comments into our chat.
Carol, I could add one other piece around supervision for cultural brokers.
Please.
This will come up in the presentation. One of the complexities is often if you're on a mental health service provision team with a cultural broker providing service to a community, that cultural broker may be a community leader, and by design is often embedded within that community. However, so then what happens is, in terms of who's getting a phone call or a text or a message for help on the weekend or late at night, it's often the cultural broker, not the clinician. And the cultural broker may be then in this situation where that individual has to navigate, okay, this is my role as a community leader, as a community stakeholder, someone that really people look to, and then this is my role as a member of a mental health service provision team, and how do I navigate that? And sometimes it's easier and sometimes it's more challenging, and trying to use supervision to understand those differentials is often really valuable to helping culture brokers so they don't have to decide those things on their own.
Great, thank you. A question that came in to us during the presentation when we were talking about kind of creating that list during the assessment phase, making sure you're using linguistically and culturally appropriate language and being sensitive around not pushing too far into trauma histories during kind of that assessment phase. The question was around, do you know of or have recommendations for samples of questions that we could, that you use or we can share with our audience members today? Or would you kind of refer to that resource in the DSM?
Yeah, I just like to use, I don't know if the DSM has specific sample questions to ask about trauma, but just, with a lot of the stuff, it's always helpful to have, because a lot of the stuff just doesn't translate into other languages. And so working closely with the interpreter or culture broker around giving examples for everything. So trauma is an example of that. So, a lot of people experienced really hard things during the war, during displacement. For example, things like losing a loved one, maybe physical harm, maybe harm was caused to you. Did anything like that happen to you? And that's really it. Usually when you say that, people get what it is that you're asking about. But I usually don't go much more beyond that, at least not in the beginning.
Great, and sort of kind of along those same lines, can you say more about the influence of culture on symptoms and responses in relation to the DSM?
Yeah, so the DSM has a whole section. I don't know if people have looked more recently. I mean, it's been since 2013, the DSM-5, but there's a whole section on specific disorders that are common across different cultural groups. So for example, there's one example, I think there's 9 of them right now, but in the Latinx culture, there's one particular disorder that they call, that this is their own, the words that they use to define a set of symptoms called attack de nervos. And it's a list of symptoms, and it's very common within the culture. This is how people define it. This is how people express it. And so ideally, we want to be asking, we want to look at if there's a specific client that we have that is from a specific cultural group, and they're using specific words to describe what's happening to them. Then we want to continue to use those words as we're talking about how we would treat them. And so the DSM has these specific disorders with the symptoms right underneath them, and then in terms of like symptoms that are common, usually, like for example, in Bhutanese culture. So you'll have somebody maybe that's, really dealing with depression or PTSD symptoms, but they're not gonna, talk about those symptoms that we see in the DSM in terms of common symptoms. So what we see is more, you'll have a lot of people talking about bodily aches and pains and a lot of somatic complaints. And that is kind of how they're expressing a specific disorder. So it might not fall perfectly in line with kind of what is listed in the DSM. So again, all just things that to be mindful of. And then in terms of the responses and help seeking behavior, so traditional healers and all those examples that we gave earlier during the presentation.
Thank
And
you.
if people are looking, oh, can I just add one thing, Caroline? Sorry. Just to build off what Luna said, sometimes if you're just doing online research around a particular cultural group, sometimes the term cultural idioms of distress is sometimes, it's a little bit of an older term, but that's sometimes a term that if you search that term and then a particular cultural group, you may find your way through the labyrinth of the internet to information that could be helpful.
Thank you both. We're getting some really great questions in the chat, so thank you all. A few have kind of come in around this situation in which working with other providers who perhaps aren't doing the cultural humility work themselves. Questions have come in around approaching conversations with providers who don't believe in families' cultural tools, such as voodoo, witch doctors, espiritismo. Same thing for families who might practice black magic and they're getting overly or incorrectly hospitalized for being psychotic because of the family's cultural beliefs around black magic. Do you have any recommendations for supporting these families and working with other providers who are really kind of struggling to do this kind of cultural humility work?
Yeah, I can maybe go first with that. I think there can sometimes, this is how I think the most effective move that I have seen, both again, my own personal journey, giving feedback to other folks, and if I was someone who needed the feedback, is not to go heavy top down social justice warrior strategy. I've used that in the past, in earlier days of younger Jeff. And a lot of that was actually a lot more about me trying to communicate, to do identity credentialing, or to, and the information was not wrong, it just was not effective. And what can happen in that is you can actually push things further apart than are already there. And so in my perspective, and I'm not alone in this perspective, is taking a stance of curiosity with that individual. So for example, if someone says something that, again, if people are familiar with the term microaggression, often one physical individual symptom of a microaggression in a room is if you get a pit in your stomach of like, ooh, something just happened, or like a thing just happened. And if you have that experience with another provider or supervisor or whatever, is just trying to reflect back humility, curiosity. It sounds like you said this, and just say back what they said. It's called using the say back rule. Because what can happen is that they may then say, oh, no, I didn't, my gosh, I didn't mean that. What I'm trying to say is this. And it helps adjust. Or you actually are then revealing a pretty potent bias. And then that gives you, so then they've used their own language, you've then checked it, they've surfaced it again. And then you can try to, again, use some of these humility strategies. Oh, can you say a little bit more about that? Or how did you come to that perspective? To try to understand where that's coming from. And often it comes from a place of either lack of knowledge or observed pain. So either someone doesn't know, and so then there's a competency opportunity, or they have suffered or they've seen suffering. Oh, I worked with this family and insert phenomenon happened and all, what I mean? And so trying to understand where is that coming from? A trauma-informed lens is, why does it make sense that they're saying that? And then doesn't mean that it's effective. And then should we shape from that? So that's, again, in my own work, my own journey, or when people try to give me feedback, that's usually the more effective strategy.
Thank you. Let's see. Other questions have come in around addressing and working with families who have mixed cultural values. I think speaking to a little bit differences in generation. How do you, what recommendations do you have for approaching mixed cultural, either within the family or within the generations?
I can take this one. This happens all the time and very, very common, where you have a family with, the parents or the grandparents that really want to maintain traditions and keep old values from their country of origin, and do a lot of things that typically would have been done back in their home countries, continue that with children that are being raised here in the US. And then you've got kids, teenagers who are adapting much more quickly in terms of their acculturation, and adjusting to American culture, whatever that means, but fitting in and speaking the language much faster than the parents and grandparents. And so what we call that, it leads to a lot of tension between the generations because of that acculturation gap. So very common. And so a lot of the work, the family work that we do, is really around, addressing this acculturation gap directly and trying to bridge it. And a lot of that is around, communication skills that I had talked about earlier, of family members talking to each other and empathizing with where everybody else is in terms of that acculturation process. So we're not trying to fix anything right away, like this is the way that it should be. Every family needs to figure that out for themselves with support. But I think if the communication piece is there and people are really empathizing with everybody's own acculturation process and what they're going through, so parents having a deeper understanding of what it might be like for the 15-year-old who's trying to navigate 9th grade, in a new place where maybe everything is taught in English and they're trying to fit in, and how hard that is. And a lot of times there's just so much stress and people are just trying to survive, that there isn't as much talking or communicating or really listening to each other. So really building on those skills first, and teaching caregivers to listen to that and talk through that. That's the first step. And then I think, working closely with caregivers around parenting, right? Parenting in a new context is different. It's going to be different. It's going to have to be different because it's a different country. There are different laws here. It's a different culture, and so we're going to have to do some things differently. And so that's going to involve some compromises. So we can't do everything exactly the same as we did back in our home country. So there's going to need to be some negotiation, some compromising. And ideally what we want to also, the message we want to give is that bicultural children, right? Bicultural kids, so kids who can navigate both traditions and their culture of origin and maintain language, and also kids who can adapt to American culture and navigate both well, tend to be the most resilient kids. And so if we can really, talk through that and explain that to caregivers, ultimately caregivers want their kids to be successful and healthy. And so if that's the messaging, that this is what leads to the most resilient kids, is helping navigate that, kids who can navigate both cultures, then, then I think caregivers are more open to, all right, let's talk through what that's going to look like for our family. What does that mean in terms of rules, setting limits, what language do we speak in, when, and all whatever the issues are. It's going to look different for every family, but the biggest thing is the information, the education, and then the communication between family members is kind of what we're trying to help support. So things like dating and boyfriends and girlfriends and all this stuff, LGBTQ issues, all this stuff is stuff that a lot of families are trying to navigate in a new place that they maybe didn't have to necessarily back in their home countries. And so that's the stuff that we want to help families figure out.
Yes, I think language and communication is always probably the number one challenge, at least getting going when we don't share that with the client, which kind of leads into our next question here about recommendations for working with clients in settings where you can't consistently utilize or access the same interpreter for each visit. Do you have recommendations for that?
I can go first. Yeah. Right. I think it's in the ideal scenario, if you can build a collaborative relationship with a consistent interpreter and or cultural broker, however that's situated in your environment, that's ideal, because the relationships are at the center of the work. And the more that you have a collaborative relationship, both as human beings working together, and then also you have that shared knowledge about what previous sessions were like, the work is it's more effective and it's more fun, and you're able to build trust more effectively, because if you're depending on the amount of interpretation or engagement with the cultural broker, you may have to reestablish that working relationship every time, or at least a piece of it. And so I would say the first step is really try to have consistency. If you can't have consistency, understanding within the system, why can't you have consistency? Oh, well, we contract with this interpretation company and this is how it's set up. And then my boss said that, okay, let's just really make sure that's the case, because sometimes we can get into these things where, oh, we never actually told the interpretation company that this would actually be helpful. And is it possible to request this person? Oh, yeah. Oh, well, so I've heard that happen. That happened to me once. And then the other piece is, so then if it's really not possible, then surfacing that directly with the client and the family and naming that with the interpreter and seeing how that unfolds and how that's working and what's gained and what's lost, rather than trying to pretend it's not there. This is not a model where we're saying, and this is not an effective model for interpretation in mental health in general, of just like, oh, it's just I'm speaking into a computer and it's coming out. That's really not what this is about. So I'd say directly surfacing with the family. That's a strategy that I would utilize.
And then always taking just even 5 or 10 minutes before and after to talk through what's happening. What are we going to do? What's the point of this meeting? What are the goals? What's the agenda? Giving time for the interpreter to think through how they would frame it, and then debriefing after is always best practice, before and after, so that time that you have in the middle is that much more effective and productive.
Yeah, I think with all things cultural humility, naming it is the name of the game, right? Like calling out how our own identities appear, but also kind of calling out, sort of as Jeff said, that we as providers want to be able to communicate with our clients as much as we can, and sharing in sometimes the frustration around language barriers, because I think in my work a lot of clients want because in a position of power and authority as a provider, they only want to do right by you and communicate with you. But I think showing that you're sharing with them and that you want to be able to communicate with them in the same way can be powerful. A great question came in also around Afghan clients in particular. I know our cultural consultant, Farah, did have to leave our session. I don't know if she left notes for Luna or Jeff around how common somatic complaints for symptoms of distress can be. I think it's pretty common for many refugee and immigrant groups in my experience. I'll also do a quick plug for our partner Switchboard, who has further trainings, I believe, not only on working with Afghan clients and recent Afghan arrivals, but I think they also have some case management trainings that look excellent coming up around case management with refugee and immigrant youth. So check them out. Did you have anything further to add on that, Luna or Jeff?
I would just say somatic symptoms in my personal experience, professional opportunities to interface with folks, I think that is relatively common. And I think, again, continuing to anchor towards cultural brokers or cultural content experts to try to understand that is really the strategy. But I think overall, physical complaints, as Luna alluded to earlier, are quite common as like the way in for talking about psychological suffering.
Great. And I think I have two more, but if you have a burning question, please, again, put it in the chat. Can you speak about documentation and any recommendations around not perpetuating discrimination and bias in notes or charting?
Yeah, so one really concrete takeaway is being thoughtful about what needs to be in the note and what doesn't need to be in the note in terms of documentation status. And there's been information in the news in past around organizations that have tried to navigate this in ways that are more effective and less effective. And so one of our general recommendations is, again, being really mindful about what needs to be in the note and what doesn't need to be in the note and what does that serve. Often there's particular information that doesn't need to be in the note and you're being fully ethical, honest. Family reflected on the stresses of acculturating to life in the United States, period, as opposed to something like, given families undocumented status, and because of this, none of that stuff is necessary for that note because the work that you're doing is helping them navigate the acculturation or resettlement stressors.
Yeah, couldn't agree more. And could you also speak to how to incorporate addressing distress related to racial trauma?
Yeah, so I really appreciate the question. For me, I'm coming into this as a white man, so that's my identity positionality inherent when I'm doing that work. I would say there's so much to say. I can't do it in this short period of time. I'd say one thing, if you're a white provider working with a Black or African-American or BIPOC identified client, that person often is going to look to, this is in my own personal experience, working with Black patients, clients, families, that person's often going to look to you of trying to assess, is this someone that I can engage with in this material? Is this random white man who I've never interacted with before? Is this someone who I can do this? And I have a Black Lives Matter sign. That is a optic tool. That is not the answer. You have to show with your behaviors that you are someone who is able, open, willing, fallible to engage with that material in a pretty deep and authentic way. And not coming in with, I have the answers, but coming in with, I really want to co-voyage with you in this information, insofar as we're able to do that in a way that feels effective. Creating a safe space is often not, safety is defined by the client, patient, student. It's not defined by the provider. And so what you can do, for example, if I'm a white provider trying to create an opportunity to talk about the trauma of racism, I'm trying to create a brave space for someone to sort of engage with me about that. And so again, invite bravery as opposed to create this artificial environment of safety. Then if you're saying, okay, those are biggish ideas, what can I actually do? Starting off with validation. One of the great failings of older models of psychotherapy is trying to use cognitive restructuring strategies for example, Black youth who are experiencing racism and saying, oh gosh, I feel like, for example, I feel like that person was following me in the store. Oh, well, let's check the facts on that one. I feel like maybe that's her anxiety. If you're noticing that, try to pump the brakes and step back, and how can you validate that affect first? And then, depending on your relationship, trying to surface, do you think that race or racism was at play here? Or something that opens it up, again, after you've built a lot of trust. So there's a lot, I think a lot there, many people more expert than me, and a lot of great material online to try to continue to engage with that.
Okay. And I think that's a pretty good note to end on. So I'll just give a big thank you again to our wonderful panelists and our audience today. In the coming days, you will be receiving a follow-up email that will include, again, the link to this recording, a copy of our slides, and a post survey link to get the CEUs. Please complete the post survey. If for some reason you don't get the follow-up email, it does come in bulk, so check your spam or email me. And also stay tuned for an invitation for our next session, session 3, forced migration experience, that will take place on Monday, March 21st at noon Eastern. We look forward to seeing you all again, and thank you so much for joining us today.
Thank you, everybody.
Thanks everyone so much.
Thank you.